All right, good morning, everyone. My name is Sara Graciaa. I'm a pediatric nurse practitioner at Children's Healthcare of Atlanta, and today I'll be talking about relapse prevention and immune TTP. I do realize that I am the last thing between you and lunch, so we will go ahead and dive in. These are my disclosures. So, quick outline of the talk today. I'm going to briefly cover what causes acquired or immune-mediated TTP and initial management. We will talk about rate of relapse as well as risk factors for relapse. I do want to touch on a few new definitions in the scientific literature regarding TTP outcomes. And then finally, we will talk about how to prevent a clinical relapse. So what is TTP? I know you've reviewed this today. We'll do a quick recap. So TTP is a potentially life-threatening blood clotting disorder that causes blood clots to form in small blood vessels throughout the body. It's extremely rare, with an incidence of about 3 cases per million per year in adults and 1 case per 10 million in children. TTP most commonly affects the brain, the kidneys, the heart, but any organ can be involved. And it is characterized by thrombocytopenia, the low platelet count, hemolytic anemia or destruction of the red cells, and reduced or absent ADAMTS13. If left untreated, it has greater than 90% mortality rate. So here we have an image of blood under a microscope. So on the left, you can see normal blood smear. You have red blood cells, which are nice and round. You have the platelets, the purple clumps that you see there. On the right, this is a blood smear taken from a patient with TTP. You can see that there are far fewer platelets, if not any. The red blood cells are also fewer in number, and the shape of the red blood cells looks different. If you look at the red cells marked by the arrow and the squares, they look fragmented or injured. So this is a picture of a normal blood vessel. On the top here, we have the endothelium, or the lining of the blood vessel, in purple. The red is von Willebrand factor, a sticky clotting protein that we know is central to the development of TTP. And then the platelets, if you can see here, are sticking to the von Willebrand factor. Platelets are what, of course, help us so that we don't bleed or bruise too easily. So under normal circumstances, the von Willebrand serves as a glue between the platelets and the blood vessel, and it helps to mediate clot formation. Von Willebrand circulates in varying sizes, and we know that the bigger the protein, the stickier it is. So normally the body controls this process very carefully with a protein called ADAMTS13, which I've shown here as a pair of scissors. So ADAMTS13 cuts the von Willebrand protein into smaller, less sticky subunits. So TTP occurs when you don't have the right amount of ADAMTS13. When we have deficient levels, this leads to the accumulation of the ultra-large or long von Willebrand protein, which then bind platelets spontaneously and form clots. And this clotting uses up your available platelets. So small clots form all over the body. The red blood cells, as you see here, as they're passing through the small vessels, are sheared or broken while they're trying to pass there. And your red blood cells are breaking apart faster than your body can replace them. The blood clots also block supply to critical organs, and this can prevent your organs from working properly and can lead to damage. So ADAMTS13 deficiency can be immune-mediated, meaning that your immune system is attacking the ADAMTS13, or it can be congenital, resulting from a genetic mutation, meaning it's something that you're born with. So the focus of today's talk will be on immune-mediated TTP. You may have also heard it referred to as acquired TTP. So now we've quickly recapped what causes TTP. We'll move on to initial treatment. TTP treatment centers primarily around 3 goals. Firstly, to replace the missing or deficient protein, the ADAMTS13. Secondly, to suppress the immune response. So here the goal is really to reduce the production of the antibodies against ADAMTS13. And lastly, to prevent clot formation. So we do this by blocking the interaction of the platelets and the sticky protein, the von Willebrand factor. So therapeutic plasma exchange is really the cornerstone of TTP treatment. During plasma exchange, plasma is removed from the blood and it's replaced with healthy plasma, which is the fluid part of the blood that carries the blood cells. Plasma exchange replaces the deficient ADAMTS13, but it also removes the anti-ADAMTS13 antibodies, as well as the large sticky von Willebrand factor. So during exchange, a central line is placed. The patient is hooked up to the apheresis machine, which you see here. Machine separates the blood into different parts. And the plasma, which again contains the antibodies and the von Willebrand factor, is isolated from the blood and discarded. The patient's blood cells are then combined with donor plasma, which contains functional ADAMTS13, and delivered back to the patient. This is typically done daily until the platelet count is normal or over about 150,000 for 2 days. So plasma exchange really transformed TTP from a universally fatal disease to one that nearly most patients survive, with a mortality rate of about 10 to 20% now. And that's likely even lower now with newer agents that we have. All right, in addition to plasma exchange, the recommendation is to give steroids and rituximab. Steroids, we typically use prednisone, slow down or stop the production of antibodies, allowing for the recovery of functional ADAMTS13. And they're given usually initially IV and then by mouth and tapered over time. Rituximab works by destroying B cells, which are the antibody-producing cells. So the B cells produce antibodies that clear or inhibit ADAMTS13. Rituximab depletes these cells, thereby preventing continued antibody formation. Ritux is typically given once a week for 4 weeks, and we start to see a response about 10 to 14 days after the first dose. Historically, we reserved rituximab for refractory or very difficult to treat cases, but we know that early use of it can reduce the number of plasma exchange sessions needed, reduce the length of hospitalization, and even prevent or potentially delay the time to relapse. So we consider upfront rituximab as a standard of care. So now I want to talk about the first and only FDA-approved treatment for immune TTP, which is caplacizumab. You may also know it as Kablivi. So caplacizumab works again by preventing the binding of platelets to the von Willebrand factor. So here, if you can see my cursor, this is the platelets. This red protein here is von Willebrand factor. So caplacizumab, which is shown here in blue, is a very small protein that targets a specific part of the von Willebrand factor and prevents the platelets from binding there. So by preventing the platelet from binding, we prevent the clot formation and then the ensuing damage that we see from that. Now, we must remember that caplacizumab does not modify the immune response for the patient, so we have to give it in addition to rituximab and steroids. It's usually given as a daily injection under the skin for about 30 days, and this is following either the last plasma exchange or until the ADAMTS13 activity has recovered. Now, caplacizumab is FDA approved for adults, not yet for pediatrics in the United States. That being said, we have used it many times with excellent response, and that is true in both the US and abroad. So numerous trials have demonstrated the efficacy of caplacizumab when added to standard treatment. The Hercules trial compared patients who received caplacizumab to those on placebo, and the caplacizumab group had achieved a normal platelet count faster. So this graph represents the proportion of patients with abnormal platelet count. So ideally, we want to see this line decreasing, meaning that a higher proportion of patients had a normal platelet count. So the caplacizumab group is here in orange, and the placebo group is in blue. So you can see that the caplacizumab group was more likely to achieve a normal platelet count, and they also achieved this goal faster. Notably, this group also experienced fewer TTP-related adverse events, which they defined as major clots, recurrence, or death. They also required less plasma exchange and had shorter hospitalizations. Now, since caplacizumab works by preventing clot formation, we know that increased bleeding is a known potential side effect. So as expected, the group that received the caplacizumab did have a slightly higher bleeding rate of about 65% compared to 48% in the placebo group. Now, I should say these events were relatively mild to moderate and primarily consisted of nose bleeding and gum bleeding. So this data really demonstrates the safety and efficacy of caplacizumab in the treatment of immune-mediated TTP. So here I've summarized the treatment for iTTP and their mechanisms of action. Just as a reminder, the scissors here, the ADAMTS13. The Y-looking figure is an antibody, and then in the third column there, we have the caplacizumab. So plasma exchange replaces ADAMTS13 and removes the antibodies. Steroids and rituximab suppress the immune system, and caplacizumab prevents the platelets binding to the von Willebrand factor, which ultimately prevent clot formation. Now, recombinant ADAMTS13 is currently FDA approved for congenital TTP. It's in trial for immune TTP. The preliminary data is very promising, but it's not currently considered standard of care. So we just described current management for immune TTP, but I do want to pause and reflect on how far we've come in the understanding and the treatment of this disease. So this year marks the 100-year anniversary since Dr. Eli Moskowitz first published the first clinical description of TTP, and he described a previously healthy 16-year-old girl who died of a mysterious illness that later became known as TTP. So I want to quickly show a video just summarizing the advancements and how far we've come in the last 100 years. Hopefully it works. If not, we can just move on. Oh, well, there's no volume. Let's see. Okay, we can just skip that, but I can briefly review it in a timeline here. So this is a timeline showing the advancements that we've made. In 1991, the first evidence-based study establishing the superiority of plasma exchange over plasma infusion was published. And again, this really transformed TTP. In 1996, a von Willebrand cleaving protein was discovered, and it was later identified as ADAMTS13 in 2001. The effectiveness of rituximab was first reported in 2002. And then caplacizumab became the first regulatory approved therapy for TTP in 2018. Most recently, in November 2023, recombinant ADAMTS13 was FDA approved for congenital TTP treatment. So as you can see, TTP has really changed from an acute to a chronic disease. We've, as providers, shifted our focus from survival to relapse prevention, preventing long-term health consequences. We've come a very long way since 1924, but we still have a lot of work to do. All right, so before moving on to relapse prevention, I wanted to stop, give anyone the opportunity to ask any questions, comment. If not, we can save it for the end. All right, so as Dr. Sukumar so nicely summarized, we know that TTP is more of a chronic disease, and that survivors often suffer from long-term health consequences such as memory problems, stroke. And we know that patients are also at risk, importantly, of relapse. So why does relapse occur? Who is at highest risk? These are questions that are yet to be fully answered. So I want to start by briefly defining some outcomes and terms that we will be using so that we can better understand the relapse prevention. The terminology that we use can be confusing. It recently changed in 2017. So here are the standardized definitions created by the International Working Group for TTP. So clinical remission is defined as a period of 30 days or more after the last episode of plasma exchange or the last dose of caplacizumab, in which a clinical response is still achieved, meaning that the platelet has a normal platelet count, that the patient has a relatively normal lactate dehydrogenase, or LDH, which is a marker of red blood cell breakdown. Clinical relapse occurs after clinical remission. It is characterized by recurrence of low platelet count and is confirmed by a low ADAMTS13. And this is what most people think of when we talk about a relapse. Now, I do want to make a distinction again between clinical relapse and ADAMTS13 relapse. So ADAMTS13 relapse occurs after clinical remission, but typically before a clinical relapse. And it's when the ADAMTS13 level falls below 20%, but the patient has no clinical or laboratory evidence of TTP. So the lifetime risk of relapse is estimated to be about 40%. And we know that relapse can occur at any time, but it's most common within the first 2 years of diagnosis or presentation. Some patients experience multiple or frequent relapses, others experience none. And again, we don't have a complete understanding of why that is. We do know that every episode of TTP, whether it's the first episode or a relapsed episode, can lead to organ dysfunction, can lead to death. And so this is why identifying predictors of relapse and early intervention is so important. So here I've listed some risk factors for relapse. Young age, meaning less than 25 years, and female sex have both been identified as risk factors. Now, I put a little question mark by them because the literature can be contradictory, with some studies finding no association between these factors and relapse, or other studies stating that male sex is a higher risk factor. We do know that relapse can be triggered by exposure to things such as surgery, infection, or pregnancy. It may sound obvious, but a patient presenting in relapse is also more likely to have future relapses. These patients have a 3 times higher risk of having a future relapse. The best studied factor we have to predict relapse currently is ADAMTS13, which we will talk about next. And finally, Black race was recently identified as a risk factor for relapse as well, and this came out of work done by the USTMA consortium. So ADAMTS13, again, is our best predictor. As the activity goes down, we know that the risk of relapse increases. And this is especially true when the ADAMTS13 activity level is less than or equal to 20%. So here we have a figure looking at 74 immune TTP patients and their ADAMTS13 activity level during clinical remission. So they found that a level less than or equal to 20% was associated with TTP relapse. The group with the low ADAMTS13 is represented here in green. The higher the line goes, the greater the incidence of relapse. So you can see that the patients with low ADAMTS13 had an increased incidence of relapse compared to those whose levels were above 20%, and this group is shown in blue. Now, I do want to mention that monitoring ADAMTS13 is very important, but a low level alone is not enough to trigger a TTP episode like we've discussed. Something else has to occur, such as infection or pregnancy. And you may have heard this referred to as a second hit hypothesis. Also, there's always going to be some natural fluctuation in our ADAMTS13 level. And so the overall trend is always going to be more important than a single reading. So in 2022, members of the consortium, led by Dr. Mazeppa, looked at the impact of race on relapse-free survival. So using the USTMA consortium registry, 645 patients from 15 centers were identified, and this spanned the time period from 1995 to 2020. So the main goal of the study was looking at relapse, how common it is, and why it occurs. So in total, 34% of the patients in the study relapsed, 40% of the Black patients relapsed, and 26% of the white patients. This here is a forest plot from the study. The risk factors for relapse that they looked at are listed there on the left. To quickly orient you, the red dot, when it's to the right of the vertical line there in the middle, the risk of relapse is increased. And if the dot is to the left, the risk is decreased. So starting at the top, you can see that age and sex did not seem to impact relapse risk. But the presence of relapse, meaning presenting in a relapse, did prove to increase the risk. And this was consistent with prior studies. Now, one surprising finding was that Black race also seemed to increase the risk of relapse-free survival, and Black patients had a 1.6 times increased risk of relapse than white patients in this cohort. And this was really the first time that this important racial disparity was noted. So as we know from the previous slide, Black race is associated with a higher relapse risk, and this proved to be true even after looking and adjusting for other factors such as rituximab treatment. So the investigators separately examined the impact of rituximab on relapse-free survival and separated this by race. So in blue, we have patients treated with plasma exchange and steroids. They did not receive any rituximab. And in red, we have the patients treated with rituximab in addition to the exchange and the steroids. The vertical line, or the y-axis, demonstrates relapse-free survival, and the horizontal line, or x-axis, shows time from initial treatment in years. So ideally, no patient would relapse, and relapse-free survival would be 100%. You would see a straight line here across the top. So as the line drops, you have more relapses. So on the left, you can see that rituximab, again in red, significantly improved relapse-free survival in these patients. However, they didn't see the same effect in Black patients. On the right, you can see that the curves are closer together, suggesting that rituximab did not have an effect on relapse risk. So once we identify that a patient is at increased risk, what do we do next? So the French group looked at long-term outcomes in TTP and in patients who were in clinical remission, but had a severely low ADAMTS13 activity level, which they defined as less than 10%. So essentially, these patients had an ADAMTS13 relapse. All the patients received rituximab prior to the development of a clinical relapse, and their ADAMTS13 levels were checked every 3 months for nearly 3 years, or the duration of the study. 3 months after rituximab, the ADAMTS13 activity level improved in 85% of the patients, and over half of them had a normal activity. Now, this figure demonstrates the ADAMTS13 activity level before and after rituximab. The dotted line there shows an activity level of 10%, and as you can see, almost all of the patients recovered functional activity. Now, unfortunately, half of these patients required repeat courses of rituximab, and the patients with longer follow-up experienced more relapses. So looking at all this data together, it appears that the protective effect of rituximab may wane with time, and there's no clear effect on overall survival. So this idea that rituximab delays treatment but does not necessarily prevent it was also demonstrated in another study out of Boston. So this study compared relapse rates between patients who received rituximab during their first presentation and patients who are treated with just plasma exchange and steroids alone. So similar to before, the rituximab treated group is in red and the non-rituximab treated group is in blue. The vertical line again shows relapse-free survival, and the horizontal line demonstrates time from treatment. And this is in months on the left and in years on the right. And then remember, as the line drops, you have more relapses. So looking at the left here, patients who received rituximab appear to be protected from relapse at 1 year. But on the right, the probability of remaining relapse-free did not differ between the two groups at the 5-year follow-up. So we know that rituximab can have a protective effect, but again, it appears that this effect is short-lived. So what do we do with patients who don't respond to rituximab or to patients who never achieve a normal ADAMTS13 after treatment? So the management of these patients can be very challenging. Sometimes we will recommend repeating another course of rituximab, and other times we'll try another agent, such as the ones listed here. I'm not going to go through all the mechanisms of actions of all these drugs, but they essentially all suppress the immune system and are all good options for difficult to treat cases. Now, when choosing one of these medicines, it's really important to have a discussion with your provider. What is the effectiveness of the medicine? What are the most serious or known side effects? Do I have any health conditions that would contradict me from getting a medicine, meaning that one medicine may be better than another. Ultimately, what is your preference? These are all factors that should be considered. Another option for refractory patients or patients who don't respond well to standard therapy is splenectomy or surgical removal of the spleen. So the spleen is a major site of antibody production. It's where the memory B cells live, and it's also the site of destruction of many blood cells. So removing the spleen decreases the anti-ADAMTS13 antibodies and decreases the clearance of the functional ADAMTS13 as well. Now, prior to rituximab, splenectomy was much more common, but it has become less common with the availability of these immunosuppressant agents. It does have a variable response. We do know that it's more effective when performed during stable disease or during remission. There is a case series of 33 patients with immune TTP who had their spleen removed for refractory disease, and 70% of the patients remained relapse-free at 10 years. So this is certainly suggestive that splenectomy can prevent relapse. But again, we can't predict who's going to respond to this and who won't. And just like any other medicine or procedure, there are risks. So we have to really weigh the potential benefit of remaining relapse-free against the risk of splenectomy. So with splenectomy, we worry about risk of clot formation. We worry about overwhelming infection. And again, these are all lifetime risks. Sorry, I've lost my mouse here. I don't know why I can't get it over. All right. So what does this mean for you? So after clinical relapse, we recommend weekly labs while we're tapering or weaning the steroids, and or at least while we're on the caplacizumab, if this is applicable to you. Do we have anyone in IT here who can help me with the mouse? I'll keep talking while we're waiting. So this monitoring, again, should include standard labs such as blood count, CBC, reticulocyte count, LDH, things that we've all talked about. But of course, we want to make sure it includes an ADAMTS13 activity profile. If the numbers all look good, everything is normal, at that point, we can space out the monitoring to monthly, and we recommend that for about 5 months. Sorry, I can't get the mouse over there. Okay.
Are you trying to go to the next slide?
No, just right here. You did that very quickly. Okay, perfect. It's just me. Thank you. All right. If the labs are normal at the 6-month mark, at that point, we recommend decreasing the monitoring to every 3 months. Ideally, we would do this indefinitely, but at least for the first 2 years, since this is when we know the risk of relapse is highest. Now, if your ADAMTS13 activity level drops below 20, or there's a significant drop from the baseline, then we would strongly recommend preemptive treatment with rituximab or another agent. So our primary approach at this point in time to relapse prevention is really to monitor the ADAMTS13 activity. I do want to mention this flow chart is available on ustma.com, and it's just one of many resources available to patients and providers. All right, so in summary, we know that about 30 to 40% of patients are at risk of relapse. The ADAMTS13 should be assessed routinely, ideally every 3 months. Persistently low levels, which we define as less than 20%, may identify patients who are at increased risk of relapse. And this is especially true for patients who've had a prior relapse. And we would definitely recommend or consider at least preemptive rituximab for patients with a severely low or downtrending ADAMTS13. So we don't want to wait for a clinical relapse to occur before intervening. So what's on the horizon? Again, as mentioned, ADAMTS13 activity is the best means to predict relapse, but it's not perfect. It's not a crystal ball. And so we really do need additional biomarkers, additional or better prediction models to predict who's at highest risk. Ideally, we need more targeted treatments to treat patients in the acute phase. And this is especially true for patients who don't respond to standard therapies. For example, we know that research is being done looking at recombinant ADAMTS13 and immune TTP. Perhaps one day caplacizumab or recombinant ADAMTS13 will replace plasma exchange, which would be wonderful. We're not there yet. And so in spite of all the advancements that we've made in the last 100 years, there's still a lot of work to do. And this is where your involvement as patients is really vital. Improving your access to research, to researchers, really helps us understand, what's important to you, what do you need, how can we help? So I just want to end by thanking you for being here. Thank you for your involvement, and I will take any questions you might have.
So the statistic about the disparity between Black race having relapses, is there going to be more studies? Like, are there studies going on to determine maybe why that is? If it's genetic, or is it something?
There are definitely hypotheses as to why that occurs. I don't think we have an answer at that point. I would assume that more studies will be done. Right. And my mentor is in the back, Dr. Chonot, so I may call on you if I have any questions. But most of the data that we have from large cohorts is out of Europe, and they have, of course, a different makeup. And so this was the first time we really saw this. But again, this was a huge cohort of nearly 650 patients in the US. So I certainly hope there's more research being done. I can't say definitively. Here, Rahul, go ahead.
As we look for relapses and such, what are some of the other reasons where one might see a platelet drop? You see not be something else.
Sorry, just to be clear. So what are other reasons that we might see a low platelet separate from TTP? Yeah, so of course, I work in pediatrics. We see it's going to be a little different. The most common reason we probably see low platelets is just infection, viral suppression of the bone marrow. We also see much more ITP or immune thrombocytopenia in pediatrics compared to adults. And so, of course, patient can always have another disorder that causes this, but a low platelet count would be extremely worrisome to me, and I would want to definitely rule out a TTP relapse, in addition to looking to other etiologies. I think you were next, sir.
What are, I know you platelets on.
Mm-hmm.
So are there specific people that y'all look at for donors? Or
That's a great question. I don't think we look at specific population. Of course, we're going to screen any plasma donors, blood donors for things like infection. But beyond that, I don't think we're specifically looking at the plasma pool.
what are some of the things health-wise?
I think health-wise, of course, we don't want anyone donating that's anemic. And so if you have any sort of nutritional anemia or issues like that, or of course, any previous history of malignancy or blood disorder, you're not going to qualify for donors, but just maintaining a healthy diet and doing everything that all of us should be doing.
Yeah. Sure, outside the treatment, they were only certain, once they found certain plasma, that's all what they see, that they were differentiating.
Okay. That's interesting. Okay. I don't know specifically why that is, but yes, go ahead.
You mentioned your test that delayed relapse.
I don't think anyone can say for sure, yes or no. I don't think it's inevitable, but I think if you have what we call a relapsing phenotype, meaning that you're going to relapse more often, multiple times, you are going to be more likely than another TTP patient. Which one comes first? Oh, which one's more common? I don't know, because we really only defined an ADAMTS13 relapse back in 2017. Dr. Chonot, do you know which is more common, ADAMTS13 or clinical relapse?
more of ADAMTS13 testing than what we did before in between the times of relapse. So we're actually trying to see them at least every 3 months, if not every 6 months.
Thank you, Claire.
And I think it's the access to care and be able to actually do ADAMTS13 for people who live far away. It's a challenge. So I'll come back to that. So I think at this point, we still see more clinical relapse, but you're right. There could be patients who may be having ADAMTS13 or biochemical relapse, as a few other providers call it. At the same time, I want to put the plug on. There's a program called Fast for TMA. Some of you may be aware of. It's a free service which actually helps in getting ADAMTS13 testing, either while in the hospital, more importantly, when you're home. So the phlebotomist, or the person who actually collects the blood, can go to your home, or you can go to a local lab such as LabCorp. They collect the blood, they send it to Mayo Labs, which is a very reputed lab for ADAMTS13 testing, and the results turnaround is usually often 1 or 2 days, and the provider and yourself can be notified of the result right away. It can be extremely helpful for following these ADAMTS13 testing, because we know low ADAMTS13 testing is certainly shown to be a clear risk factor for relapse.
It's also completely free. We don't take insurance. We don't take any sort of payment. It's absolutely free. And you can just go to our website, request a test. We contact a physician who's responsible for the results. So we do have another question as well. Are you more likely to experience seizures if you have iTTP?
As opposed to having congenital?
Is there any correlation between a diagnosis of iTTP and increased risk for seizures?
I think anytime, whether it's immune or congenital, if you have any sort of ischemic changes in the brain, meaning that you're not getting adequate blood supply, you are going to be prone to seizures. And I just wanted to follow up on the previous question. Again, I just want to make sure it's clear that having a low ADAMS does not necessarily mean that you will relapse, just an increased risk. I have no idea who was next. I'm sorry. You in the red shirt will go first.
A patient with TTP, if they live in an area where they don't have a hematologist that is doing active studies, or they're trying to maintain a non-episode maintenance schedule. How often should they be getting their blood tested or their blood drawn in order to know their levels and keep up with basically having an episode?
Right. And just to reiterate for the people at home so they can hear the question, what is the follow-up schedule for someone who is in a period of remission and just needs routine lab tests? So what would be the suggested testing schedule?
It's a great question. One that's difficult to answer, so it's going to vary by patients and the patient's risk factors. You know, if you've relapsed in the past, then I'm probably going to be monitoring you more closely. Or if your baseline ADAMS was 90 and now it's 40, then I'm certainly going to be monitoring that level more closely. But if you live at 40, you've always been at 40, then I would probably say every 3 to 6 months is sufficient. Did that answer the question? No.
Please repeat the question.
Do we have any data on the number of people that never relapse? I would assume about 60% of the patients, since we know about 30 to 40 relapse. But in terms of what that N is, what that number is, I don't know. So with serum sickness or really any infusion reaction to rituximab, whether it's anaphylaxis, trouble breathing, hives, there are other options, and there are other agents like we kind of listed earlier. There are other medicines that target the anti-CD20 or that immune cell that you certainly could use. So personally with that, if you pre-medicated and you still had symptoms, then I would use an alternative agent.
You mentioned a baseline. How would you know what that is if you've never had it?
That's great. We don't know. That's a great question. We don't know. Oh, sorry. If you're having your first TTP episode, how do we know what your baseline ADAMTS13 is? Ideally, I would hope it'd be normal, but that certainly may not be true. And so I think just monitoring every 3 months, again, initially for the first 2 years, would help us establish what your normal is.
Never mind.
I can recap after.
So just in the
Mm.
conversation, 2 or 3 weeks,
Mm.
they keep giving, what would be something, or what would be a better solution instead of taking what you're saying now? It's not.
Right. Now, that is just an association. I don't think we can, it's not as simple as if you are Black, you are not going to respond to rituximab. We certainly have patients that do. Personally, if rituximab did not work in one of my patients, I would consider something like bortezomib or Cytoxan. I know other people use things like cyclosporin, other agents, but we have lots of other options. Go ahead. Yeah.
So what is, in 4 years, 3 weeks, one course, that's just in try to get. So taking the same one, keep that.
Right. I wish it weren't normal.
Would you recap the question?
Oh, I'm sorry. In 4 years, I've had 3 relapses. Is that normal? Is that expected? It's really going to vary person by person. You know, I have some patients who have 1 episode and never relapse again, and I have others that have had 5 or 6 relapses in spite of close monitoring and, you know, equal access to care and standard treatment. So,
If I may quickly to
Oh, yeah.
follow up on that, I think it's important what we do is when you, after the rituximab is given for relapse, we want to ensure that you actually go into remission or clinical remission after the rituximab. So follow up of looking at the platelet levels, the ADAMTS13 levels very closely after the treatment. So the challenge is that when they do not go down, then you know, it's fairly obvious that you're not someone who may be responding to rituximab as effectively. It's also possible that you might have responded to rituximab a year ago and not subsequently. And our body changes, immune system changes slowly as well. So yes, it's possible to have multiple different medications, but I think rituximab is something which is most studied, and across the world, we have a lot of patients who still receive it upfront. Hence, that's still our first line to use because, like Sarah said, a significant number of people do respond to rituximab effectively. But the key is to follow them really closely after.
Leanne, did you have a question?
Oh, I was just going to chime into
Yeah.
the question earlier about serum sickness and some alternative agents.
Oh, yeah.
We have used another agent that wasn't listed. I think it's maybe approved for use in the UK now, the obinutuzumab for patients who've had serum sickness or adverse reactions to rituximab. It's the same thing. It's weekly ×4.
Yes.
Are there going to be research studies done on deficiencies like anemia or levels?
It's a good question. So the question is there any association or studies looking at the frequency of anemia or iron deficiency in TTP? Not that I know of. Certainly if you have TTP and you are bleeding, then you are going to be more likely to be anemic and iron deficient. So there are other reasons that you could be anemic post an episode that's separate from the TTP. So it's always important to test those and rule things out.
I do want to stress that the USTMA registry is collecting all that data from patients who get part of the registry. These information are collected. So hopefully in the next few years, we can see how many of them have had other questions, answer to other questions being asked, how many have had a biochemical relapse, or how many never had a relapse before. So we certainly can gather more and more data from the United States.
And I think this will have to be our last question.
Okay.
And then when we wrap, I'll give all the details on lunch, but go ahead.
Mhm.
How can you recognize or test what you're feeling if you're
So is the question, can you still have symptoms if you have normal platelet count and your Adams is low? I think the answer is certainly yes. We're learning more about that. It's going to vary by patient. I do have patients tell me that, most commonly frequent headaches, for example, issues with memory, which again, that certainly could be a long lasting, neurocognitive effect. But if it's worsening, there's any acute change, then I'm going to start looking more closely, maybe do an MRI, look at the Adam TS13, do a CBC. What I would say is, you know yourself better than anyone else, or in my case, the parent knows the child the best. So if he or she is not acting right, if you have symptoms that are similar to your initial presentation, then you need to bring that to the attention of someone.
Great. Well, thank you. I think this was just an amazing session, and I think all the sessions today were great. So we do have a lovely lunch buffet set up. If you have any dietary restrictions or you need a vegan meal, we have those set in the back. So please just let someone know. It's an Italian buffet, and there's a pasta chef who's frying up fresh shrimp and stuff like that. So make sure you swing by, and we will resume at 1.